Welcome to Nourish MD, Doctor Dietitian Dialogues, where doctors and dietitians empower you about your health and discuss and provide a better path to health and wellness. Proudly presented by Concierge Medical Practice Private Physicians Medical Associates, PPMA, with your hosts, registered dietitians and nutritionist, Lauren Papanos and Romana Brennan.
Hello, everyone, and welcome to Nourish MD PPMA podcast. I'm Romana Brennan. I'm one of your hosts, and I'm joined here by Dr. Jenny Hu of the S02-E06 Associates Eye Center in Newport Beach. And I'm really excited for this conversation today. We're going to be talking all things eye health. Dr. Hu is an ophthalmologist who specializes in refractive and premium cataract, trigeum, eyelid, oculoplastics, and minimally invasive glaucoma surgeries. We're going to dive in today into what all of that means, and Dr. Who's going to give us some really great context in terms of what that treatment looks like, what care looks like for those different types of eye challenges and eye issues. She obtained her Bachelor in Science in Biology from Duke University and then completed a combined MD MAS degree in Medicine and Clinical Research at UC San Diego. She then went on to complete her ophthalmology residency at the prestigious Shirley Eye Institute at UC San Diego, where she operated with the world leaders in hundreds of surgical cases. And she's a firm believer in forming a partnership with her patients in achieving their individual vision goals. Dr. Who is also a proud advocacy ambassador for the Academy of Ophthalmology to help advocate for her patients at a national level. So we are so excited to have such a wonderful practitioner with us here today to talk all about eye health. So Dr. Who, very extensive background for you, but is there anything else that you'd like to share with us about yourself or your professional background?
No, really. Wow, that was a very generous introduction. Thank you so much, Romana. Especially the partnership part. I really take a lot of pride in discussing with my patients all about, what their daily activity level is, what do they like to do, what their vision goals are. And I think, tailor my treatment and my management with the patients in terms of, seeing what fits them best in terms of quality of life. And that's really, really important to me.
Yeah, and I think as a care approach, that's super important in order to really make sustainable change and counsel individuals through whatever their goals are. I mean, we see that within the context of nutrition as well, and some of the work that I do and that Lauren, our other dietitian, does at PPMA. If you're not personalizing according to the individual's goals, it's so important.
Yeah.
So why don't you start us off in just sharing some of the common reasons that patients come to see you? I had rattled off a handful of conditions and things. If you can just explain some of those, and why a majority of your patients are entering your office or joining your practice.
Right. Thank you. So to start off with, first of all, since I am what I consider a comprehensive ophthalmologist, I really see it all. I see, cataracts, retina problems. I see ocular plastic problems as well. People come to me with glasses problems, with double vision, neurological problems. I see everything. But I would say there's these top 3 diseases that we really look for, and that's probably the most of the patients that I see have these 3 things. So 1 is cataracts, 2 is macular degeneration, and 3 is glaucoma. And those are kind of the 3 things we really want to focus on and screen early, especially in our aging population. And so first of all is a cataract. And so most patients have probably heard of a cataract or know someone or know their parents have gotten cataract surgery. So what a cataract is, and I'm going to grab my little eye model here, is we have a natural lens here that sits in the back of our eye like this. And what happens is when we're born, this lens is all nice and clear. So it's like a nice clear camera lens. However, unfortunately, as we have more birthdays, that lens gets a little hazy over time from just regular wear and tear. And some people, unfortunately, have some medical conditions or take medications that can actually accelerate that process. When it gets really hazy, it becomes really difficult to look through. And that's essentially what a cataract is. And one of the number 1 problems or questions that patients ask me is like, well, what do I do about a cataract and when do I do something about it? So I always tell people just having a cataract doesn't mean you have to go straight to surgery. Everyone develops a cataract as long as they live long enough, essentially. But, we want to assess a couple of things. First of all, well, what is your vision? If your vision is really great and you have a mild cataract, then, we don't necessarily need to jump to surgery. And the opposite is true too. Like if you're having a lot of visual symptoms, then, we should probably do cataract surgery sooner than later. I would say that's one of the most common reasons people come in. One, that they think they have a cataract, they were told they have a cataract, or they saw someone else for a cataract and they want to get another opinion. And so those are very common consults that I get. So the second thing I want to talk about was macular degeneration. And so macular degeneration is becoming more and more of a prevalent disease, unfortunately, given that, well, our population is living longer and longer, thanks to, the wonderful work that some of our PPMA docs are doing, keeping their patients nice and active and healthy so that they're living long enough to develop this disease now. So what macular degeneration is basically accumulation of deposits over time in the macular region. So if we look on the eye model here again, this macula is the center of our vision, which is the retina. So the retina is actually the wallpaper of the eye here, and the macula is the center. And so there's these little deposits, these lipid or calcium deposits that build up in the macula, and that can cause vision degradation over time. What can also happen to these patients that they can develop, unfortunately, bleeding and also exudates in that same area. And we don't have to go into this in too much detail, but basically people can develop either dry macular degeneration or wet macular degeneration. Thankfully, nowadays, wet macular degeneration traditionally used to be the quote-unquote worst kind, but nowadays we actually have really great treatments. The most important part is getting evaluated, coming in and getting that diagnosis and being able to be referred to someone that can do those treatments right away. And the earlier you get treated, the better the outcomes typically are. And so that's why I always emphasize that it's really important when you're noticing any vision changes is to come right in, get evaluated right away so that we can get you the proper care that you need. Last but not least, glaucoma. And so glaucoma is a really, really tricky disease. The reason for that is when it first starts, patients don't feel anything. They don't notice anything. There's obviously different kinds of glaucoma, but the most common kind, which is what we call open-angle glaucoma, is something that's really sneaky. Okay? So what glaucoma essentially is basically chipping away at the optic nerve. And, over time, what that does is it causes some peripheral vision loss. And we as human beings, we're really good at looking through our central vision, but we're not really good at detecting the peripheral parts of our vision. And so because of that, whenever anyone has any family history of glaucoma, we tell them to come in right away and get screened, because having glaucoma in your family, at least in your immediate family, increases your risk by 10 times. And people don't really know that. Or if they've noticed that their pressures have been high, or if they've been told that on their examination they may have some risk factors for glaucoma, I highly recommend them to come in to get screened.
Yeah, thanks for all that info. I want to continue the conversation on glaucoma because I know that it's something that we see in a lot of our patient population as well. So can we go into some of those types and how glaucoma might develop, and why is it that family history increases your own risk of developing glaucoma?
Yeah, absolutely. So there's really two main families of glaucoma. There's what we call open angle and closed angle. And so what is the angle? The angle is actually a structure inside the eye here. So it's right. So this is the cornea, which is the front part of the eye. This is that lens we had talked about earlier. The angle is actually right here, right behind the cornea. It's literally in the angles of the eye. That's why it's called that. Why the angles are important is that they're actually serve as drainage pathways for the eye. So as you can imagine, the eye is filled with fluid. It's constantly making fluid and draining fluid as well. And so some people, unfortunately, are born with something called narrow angles, meaning that their drainage pathways are just a little bit thinner. A good analogy is, going home and looking at our sinks. We have different kinds of piping, right? Some are a little bit more narrow, some are a little bit wider. So some people are born with one type versus the other. It tends to be familial. So people who have family members or parents that had narrow angles tend to have narrow angles. It also seems to be more prevalent in certain ethnic groups as well. And so that's usually one of the first things we look at when a patient comes in for anything that makes us consider that they may have glaucoma, or if their family has glaucoma, we want to check their angles. So if people have narrow ankles, what can happen over time is that the production of fluid can kind of overwhelm the drainage system. So as you can imagine, if you have a clogged up sink and your water keeps running, well, you're going to get a backup. Unfortunately, your eye is not a sink. It's a closed globe, right? And so because of that, pressure can rise inside the eye, and it can cause something called, chronic angle closure glaucoma. There's also something very scary, which we call acute angle closure glaucoma. What happens for that is that the drainage pathway actually close up. And if they close up, that pressure spikes really, really high, and it can cause very rapid and very permanent visual destruction. And so our goal as ophthalmologists, and what I'm trying to achieve, is to, catch the people that are at risk for that first. Because, once that happens, right, then we have to basically do damage control. And, at that point, depending on how long this problem's been going on for, they may or may not be able to, retain meaningful vision. It just really depends. And so hopefully we can catch it before that time, because there's other treatments that we can do for that. For example, there's a laser we do. It's called a laser peripheral iridotomy, where we actually make a small little laser spot here in the color part of the eye. And when we make that spot, basically what we're doing, we're giving it additional piping. So we're building this extra conduit that in case the drainage pathway is completely closed up, there's this alternate pathway for the eye to drain fluid. And so that's something we can do prophylactically to prevent that from ever happening to the patient particularly.
That's so interesting. I would have never known that was a thing. But thank you for describing that in so much detail. And I love the visual that you have. Hopefully our audience is able to watch this on YouTube so they can see kind of what you're talking about with that eye visual. Can you describe the screening process for us? So let's say someone did come into your office knowing that they should screen for glaucoma, having heard this, that maybe they have that family history. What can you describe what that screening process looks like for us, please?
Yeah, so two of the most important aspects of my screening process is an optic nerve. We call it OCT, which is basically a scan that looks through the layers of the optic nerve, and we're actually able to measure it. So one of the ways, so just to back up a little bit here. So aside from family history, there's a couple other things I look for in order to kind of lead me towards screening this patient long-term for glaucoma. One of them is the optic nerve appearance. So what the optic nerve looks like is a little bit of for lack of a better analogy, a bagel, actually, the way it inserts into the back of the eye. So you know how on a bagel, there's like the bagel meat, and there's also like a dip, which is like the bagel hole. So the bagel hole is there for the blood vessels to actually go in through the optic nerve and into the eye itself. But the bagel meat part is really important because that's actually where the nerve fibers go into the eye and around, okay? So some people, when I do their dilated exam for the first time, so many people come to me, these relatively young, healthy people. They come into me, this is their first eye exam ever where they had a dilated eye exam. I can see that optic nerve in a lot of clarity. And one of the things I see most often is what we call increased cupping, which means that bagel hole is a little bit bigger than we would like it to be. Usually, I would say the average size is about 20% or so. Sometimes I have people come in with 50% or even 80%. The reason why that's concerning, the reason why we screen people that way is because when we see these big dips, we wonder if we've lost some of the nerve fiber around it, which is basically the bagel meat, okay? And so, but the thing is, some people are born with nerves that look like that, and it also tends to be familial. And so in those cases, we call them glaucoma suspects. And now moving towards the screening, well, what we want to do is instead of just eyeballing and looking at the nerve, well, we want to do a scan and count how many fibers there are. And what this scan does is basically compares the patient to, what we consider average or normal of other patients. And it can assess where they are in terms of how many microns thick their optic nerve is. What's really great about the technology we have is that over time, as you get more and more scans, they compare it back to your old scans as well and gives us a nice progression graph. So we can see whether or not you're progressing. I mentioned this a little earlier, but glaucoma is a disease of basically degradation of the optic nerve fibers over time. And it does have some relationship to pressure, although it's not exactly direct, and we can talk about that a little bit later. And so what's really important is we want to look for or rule out progression of this degradation of the optic nerve. If your optic nerve fibers stay exactly the same over time, then that's great. That's what we want to look at. That's what we want. But if they start declining over time, then that means that we need to treat. And so that's one of the ways we can screen for glaucoma. Another way we screen for glaucoma is something called a visual field. And how I usually explain to patients is that it's almost like you're playing that old asteroid game. I don't know if you're familiar with that. But what our patients do is they actually wear a virtual reality headset. So traditionally, a lot of offices have this big machine that you kind of sit in. But, a lot of our patients are a little claustrophobic. And some of them also just have neck problems and things like that, positioning issues where they really can't keep their head in this machine for, 15, 20 minutes. And so we've actually developed these virtual reality goggles where they can just put it on, they can get into a comfortable position in their chair, and they can just really take their time and feel more comfortable doing that. We found that the patient's results are a little bit more accurate this way, which makes sense given that they're more comfortable taking the test. And so we've really adopted these virtual reality goggles. So there's going to be a bunch of bright lights that are being shown through the goggles, and the patient's supposed to click whenever they see a button. This way, it tests for both central vision and also peripheral vision, which is even more crucial for glaucoma.
That's so interesting. I love the inclusion of these advanced technologies as well. I think that's so important to have those more accurate screening procedures so that we can better serve those populations. I think that's fantastic and so interesting. I don't think this is something that a lot of people know about. So I'm very happy to have you here and describing this process for us. Looking for expert nutrition advice? PPMA offers one-on-one consultations with a registered dietitian to help you achieve your health goals. Whether you need a personalized meal plan, weight management tips, or guidance on managing a health condition, our dietitian is here to support you every step of the way. Visit privatemds.com to schedule your consultation today. When it comes to the preventative piece of things, because it sounds like glaucoma to an extent might be somewhat preventative. Is that correct? How much can we influence the development and progression, I suppose, of glaucoma if we are someone who is potentially at risk or a quote unquote suspect of glaucoma?
Right. So that's a really good question. So glaucoma, the main goal of glaucoma is to slow down progression as much as possible. It is a progressive disease. We don't quite have a cure yet. And that's what I emphasize to all my patients. The vision loss that occurs in glaucoma is typically irreversible. In some very, very mild stages, you might see some improvement, but usually that's not expected. And so as you can see with a disease that has no cure, we want to A, screen for it, B, find it as soon as possible, and C, treat it to slow it down as much as possible. My goal, and I tell my patients this, is to slow down so much that it doesn't affect your vision for the rest of your life or any more than it has already. And that's my goal, to just slow it down so much. Until the day we develop, optic nerve transplants, unfortunately, we're probably not going to have a true cure for glaucoma pretty soon. But, there's been a lot of amazing research that has happened in glaucoma. I would say, if anything, it's been one of the most promising fields, I would say, recently that's had the most advances. And so, hopefully at some point we'll have that cure. But right now, since we don't, we got to just work on screening for it and finding it earlier. Yeah.
Understood. Yeah, that makes sense. So can we talk a little bit more about some other conditions where it might be less of a treatment or reversing that vision damage or that vision loss, and maybe it is more so of preservation of the vision that you do still have and slowing down the development to as best of an ability as you can? What other conditions are similar to glaucoma in that vein?
I would say macular degeneration is pretty similar too. Once you really start developing those deposits that are affecting your central vision, those deposits don't shrink. They don't really go away. I get patients that ask, can you just use a laser and zap it? I'm like, that's not exactly how it works. But we can slow it down. And so because macular degeneration, a lot of it's related to oxidative damage to the eye, we always talk about how important it is to wear UV protection when you're out and about, especially my fellow golfers. People are always out in the sun all day. It's really important to wear UV protection at all times when you're out and about to really decrease the progression of those deposits, especially if you have a family history. Because, they work really hard every single day of our lives. And those are actually found in a lot of dark leafy vegetables. So, our kale or lettuce or spinach. And so I always, tell patients to try to keep as much of a rainbow meal as possible. I'm sure you guys talk about that in nutrition all the time too. And to really incorporate those leafy greens into their diets. When I really see someone that's progressing in, macular degeneration despite all the lifestyle changes, then there's actually a vitamin out there called S02. You might have seen that on the shelves here and there. Preservision is the one that's sold in Costco. And so, they're basically essentially the same thing. They all have lutein and zeaxanthin. So if I really see someone progressing, then we'll discuss, starting this on the vitamins, or let's say they're really incapable of making these changes and they have a strong family history. Everyone's situation is very individualistic. And so I basically work with my patients to see what's realistic for them and where I think they need to, start, how aggressive they need to be in terms of preventing macular degeneration.
Yeah, absolutely. From a nutrition standpoint, that's certainly something that we chat about a lot, and something that I counsel a lot of individuals on is how can we increase those antioxidants, not only for eye health, but so many other aspects of our health as well. But those two that you pointed out certainly being something that we chat about often. So it sounds like from a nutrition perspective, there's a lot that we can do to help support this. And then also something else that you mentioned being that UV protection. Is that any pair of sunglasses? Do they have to be polarized? Does it matter?
I wouldn't say the polarization matters as much, but it definitely needs to be UVA blocking.
Okay. That's helpful. Thank you. Any other strategies that individuals can start on today? Maybe they recognize that they need to be a little bit more mindful of some of the tips and strategies that they're implementing to support their eye health. Anything else that you've seen to be especially effective in helping prevent these conditions and preserve vision loss?
Yeah. So, just maximizing and optimizing your cardiac health is really important. A lot of my patients have high blood pressure, or they have diabetes, and just really being able to optimize that will really also help as well. There's a lot of diseases that can come from hypertension and diabetes. Just diabetic retinopathy is one of them. Hypertensive retinopathy is another. You can get bleeding in the back of the eyes from all of this stuff, and so it's really important that we manage the body medical conditions as well as the eye health. There's been some research that shown that 158 minutes of cardiovascular exercise every week is very helpful too. So that also plays into that as well. So yeah, those are just a couple of changes. I would say, initially you asked me what were some of the most common things I see, and dry eye is one of the most common eye diseases that I see. And there's been some more recent research that's shown that omega-3 fatty acids can also really help a lot with dry eyes, among various other things as well.
Yeah, I'm glad you brought that up. I know DHA, which is one of those omega-3 fatty acids, is so important for eye health, making up a big component of the fatty acids that are comprised within the eye. So I'm glad to have mentioned that. So again, from a supplement perspective, there's a lot that we can do. From a nutrition perspective, even more, right? And that's something that we'll definitely have a conversation on in our next podcast episode. So for anyone listening, be sure to catch that one. As we're chatting about these different conditions, can we talk a little bit more about some of the treatment approaches? I mean, we've discussed in detail about glaucoma, where treatment looks a little bit more like management, at least for the time being, until we work on some additional strategies and finding a cure for that damage to the nerves. Can we talk about some treatment in relation to cataracts, diabetic retinopathy that you have mentioned, even age-related macular degeneration, I know, similar to glaucoma? What does treatment look like for an individual who is dealing with a variety of these different conditions?
Right. So that's a great question. Just to backpedal a little bit here, for glaucoma, actually, there is treatment, but I tell people that the treatment that we're doing is actually just to slow it down more, not to actually cure glaucoma. And so, unfortunately, some of these treatments have to be lifelong. And so, one of the first things we would do is actually start them on medicated eye drops. And what these eye drops do is they basically lower pressure of the eye. There's two ways to do that, either by decreasing the amount of fluid that your eye is producing, or increasing the outflow, decreasing the resistance to drainage. And so those two mechanisms. And so that's usually the first step. There actually has been some research that's shown that doing a laser earlier on in the treatment pathway may actually be more helpful. So one of the laser treatments we can do is something called S02-E06, which basically opens up the drainage pathways of the eye. And so we can actually use power to do that on the laser. And so it used to be more traditionally that we start with the drops first, then we go to the laser. But now more and more people are starting to do that laser because, as we've seen over time, some of these medicated drops do have some side effects long term, or sometimes our patients get really bad, irritated, dry eyes with some of these drops. And so doing the laser is actually a way for people to get off drops. And so we've been introducing that a little bit earlier. Unfortunately, there are people that end up needing some kind of more invasive incisional surgery if none of these other treatments work. So unfortunately, needing like a drainage device or something like that in the eye. We actually take a lot of pride in this office that we catch people early enough to stop them from needing that glaucoma surgery. And so, we consider that a win if we can save someone from needing that for the glaucoma surgery. So I just wanted to talk about that for a brief moment. So talking about some of the other conditions, so cataracts. So the obvious cure to cataract is cataract surgery. And so what we basically do in surgery is we make a small incision on the front of the eye here. We go inside the eye and we actually take out this natural lens. This natural lens actually sits inside a little bit of a thin bag inside the eye. And I make a small incision and I break up that cataract and I suck it out with ultrasound force. The reason I leave this bag intact is we got to put a new implant. That's what some patients don't really realize is that once your natural lens comes out, well, we got to replace it with something, or else you're not going to have a lens that focuses light properly on your retina. So you're not going to be happy. One of the common question I get is actually patients ask to not get a new lens. I'm like, no, you want it. Definitely you want a new lens in there, or you're not going to be able to see well. So we put a new lens in, a prosthetic lens. What is super exciting about cataract surgery these days is we have fantastic lens choices. We have the standard lens, which is the one that I think most people know is covered by insurance. That is a terrific lens. It really focuses light and gives you fantastic image quality at a particular distance, whether it's up close or far away. And this is where that partnership comes in. When I sign patients up for cataract surgery, we spend hours talking about this stuff. We talk about what their lifestyle is, how active they are, where do they like to read. I measure that and I can tailor things to whatever they would like, as much as I can, of course, within reason. And in addition to the standard lens, we have what we call these premium lenses these days, which they give you multifocality where you can see some distance, you can see a little bit intermediate and up close. And there's also a mix of lenses that can do a little bit of a more like a gradual, like almost like a progressive in some ways, but not quite, where people have to look straight ahead and look down. You don't have to do that. You just look straight ahead. And so I think, this is the golden age of cataract surgery in a way, and that we're really seeing these amazing lenses come out that can really just give patients their lives back. And sometimes patients will tell me that they feel like they're 10 years old again. And they're just so excited about their vision. And that's always really rewarding to hear.
That's amazing. I hope that this conversation gives some individuals some hope that there are options out there for you, especially if you were to see someone like Dr. Who will take the time to discuss all the options for you. Can we chat briefly about diabetic retinopathy and what the treatment options look like? Of course, we have a good understanding of the root cause of those types of eye issues, but let's chat a little bit more about that and from your perspective, kind of what that treatment looks like.
Yeah, sure. So diabetic retinopathy actually comes in multiple stages. And so whenever I see just mild diabetic retinopathy or just the beginnings of it, I have a really long sit-down conversation with my patient because I tell them that this is the time for them to optimize their blood sugar. You don't want it to wait till it starts affecting their vision. There is a certain point where it becomes irreversible. Once people get to the more severe category, and unfortunately, there's a later stage we call it proliferative diabetic retinopathy. That's when things get really bad, when there's all these very abnormal blood vessels that grow inside the eye because of diabetes, and they can bleed because they're so fragile and they're really abnormal, and they bleed and they continue to re-bleed. There is treatment for that, but I do tell them that at that point it becomes irreversible. So I have patients, unfortunately, that developed it at that point, and now their sugars are perfect. But because that has already happened, that process, it's irreversible. So it's really important to have that strict blood pressure and blood sugar control early on. In terms of actual treatment, so over time, if unfortunately they do develop that end stage, have diabetic retinopathy, what we can do is we can do injections. These are called anti-VEGF injections, and they're into the eye. And so, that always scares patients initially, but I always reassure them that these treatments are actually very painless, believe it or not. The needles are very small and, the procedure is very safe. However, it is usually sometimes a monthly or, every 3 month treatment. And so obviously we want to prevent as many patients from getting there as possible. What that medication does is basically helps the blood resorb, essentially, and tries to decrease the sort of creation of these abnormal blood vessels. But sometimes, unfortunately, that's not enough, and they end up having to get laser. Some of this laser is basically aimed at controlling these abnormal blood vessels from proliferate even more. But, unfortunately, sometimes even despite our best efforts, though, the diabetic retinopathy can still progress, which is why, like I said, getting it early and controlling it earlier is one of the most, treatment, if you wanted to call it that, available.
Yeah, absolutely. Well, thank you for taking us through all of that, Dr. Hu. For anyone listening who may not be familiar with you or your practice, but who might like to schedule a consultation, can you tell them where they can learn more about your practice?
Yeah, absolutely. So you can definitely visit our website at astorinoeyecare.com. We also have a social media at Instagram that's a little bit on the newer side, so bear with us. We're trying to, put up some new content here and there. But you can follow us at AAEC_IEY.
Awesome. Well, thank you so much for your time today, Dr. Hu. I hope that everyone who is listening got some great takeaways from this episode. If you're having vision issues, please go get a screening done. Super important to have that early information in terms of what we might be dealing with and have that baseline. So you can always contact us if you're a patient at PPMA for us to set you up a referral with Dr. Hu or one of her other colleagues. And you can reach us at privatemds.com. Thanks so much, everyone, for tuning in, and catch us in 2 weeks for another episode.
Thank you so much for having me.
Thank you for joining us for today's episode of Nourish MD, Doctor Dietitian Dialogues. This podcast is intended for general educational purposes only. It is not a substitute for professional medical advice. Please consult with your healthcare provider before beginning any nutrition or supplement recommendations. Sign up for our mailing list so you'll never miss an episode of our wellness journey. See the podcast description for the link.